Welcome one and all to this Sunday afternoon of knowledge and enlightenment. Today we are going to discuss on updates of role of NTD in immunoglobulin in Rh negative pregnancy with the experts under the aegis of Foxy Perinatology Committee along with Allahabad, Agra, Firozabad, Mathura and Meerut. This webinar is brought to you by Bridging Bharat Initiatives by Bharat Serums and Vaccines. So to start with the webinar, I would like to introduce our co-moderator for today. That is Dr. Diksha Goswami Sharma. She is the Director Pushpanjali IVF, North Zone Coordinator Perinatology Committee Foxy and Librarian UP Chapter E-Star. She has been awarded as the first runner-up for Shanti Yadav Award in Fertility AICOG and awarded 13 gold medal during the entire academic years. She has been the winner for Best Paper Women's International Health Summit Hiralal Gold Medal for first in the Obscene and overall Best Girl Trophy MBBS. She has contributed many chapters on infertility and her special interests are PCOS, reproductive endocrinology. So over to you, Dr. Diksha ma'am.
Thank you, and a very good afternoon to one and all. I take this opportunity to welcome all my seniors, colleagues, and dear friends to this Foxy Perinatology Committee webinar today, which is co-hosted by the Agra, Allahabad, Mathura, Meerut, and Firozabad societies, along with our academic partners Science Integra, TOG, and Bharat Serum. It gives me great pleasure today that so many of the dynamic societies of North Zone agreed to come together with our committee on this Sunday for this academic extravaganza. And today's topic is a case-based discussion on Rh negative pregnancies, and we'll be discussing the role of anti-D immunoglobulin. This is really clinically apt as 3 to 6% of Rh negative Indian women deliver today. And many of them, about 16, have the risk of isoimmunization in 16% of these pregnancies. Anti-D immunoglobulin by itself is a success story of modern obstetrics and has the potential to reduce the complications in these women to almost less than 0.2%. Saying this, I invite Dr. Vaishali Chavan, who's a dynamic chairperson of Foxy Perinatology Committee. Ma'am is MD, DGO, Diploma in Endoscopy, DNB, DFB, and FICOG. She's the director of Sahidri Super Speciality Hospitals in Pune. She runs the Sanvi Clinic. And ma'am is, I would like to say that she's not only a skilled clinician, but a great leader and has mentored many young Foxians to work for the committee across all zones of India. She has received many awards like the Punya Bhushan Award in 2017, the Samaj Bhushan Award, the Gaurav Puraskar, the Lokmat Award, and the Inspire Gynecologist of India Award. Welcome ma'am, and really a big thank you for this opportunity.
Thank you, Dr. Diksha, for this wonderful introduction, and a very warm welcome to all of you for today's webinar. This is a Perinatology Committee Foxy webinar in association with Agra, Allahabad, Meerut, Mathura, and Firozabad Society. Many thanks to Science Integra TOG and our academic partners, Bharat Serum. I would like to thank in the beginning Dr. Alpesh Gandhi, President Foxy, for this opportunity, and our Vice Presidents, Dr. Archana Basan and Dr. Ragini Agarwal, who's with us today, and also ICOG for accrediting us one ICOG point, Dr. Mandakini Meg and Dr. Parag Biniwale for giving us this ICOG credit point. We have been doing a series of webinars on Rh negative pregnancies, so this is one of the series, the continuation of the series. And for today's webinar, we are indeed blessed that we have with us two guests of honors, Dr. Narendra Malhotra. As we know, he is the legend of legends, and sir's a huge work, and especially for a topic like Rh negative pregnancy, where so much fetal medicine is involved. So sir, we are truly blessed that you are with us today, and you will be giving us a few tips and advice about this topic. Our second guest of honor is Dr. Ragini Agarwal, and ma'am is the very dynamic Vice President Foxy, and ma'am will also be guiding us today. I would also like to thank especially Dr. Diksha for organizing this webinar so well, and all the faculty who are with us, Dr. Vandana Chadda, Dr. Richa Singh, Dr. Dipali Garg, Dr. Poonam Agarwal, Dr. Vinjana Pandey, and Dr. Priyanka Garg. So I hand over to you again, Dr. Diksha, to give a formal introduction of our guest.
Yeah, thank you, ma'am. First, I would like to really thank from the bottom of my heart Dr. Narendra Malhotra. Sir is actually the backbone of Agra Obs and Gynae Society and has mentored so many of us young obstetrician and gynecologists. Sir needs no introduction. He is a professor, Sarajevo School of Science and Technology. He's a director of the Iron Journal School of Ultrasound, vice president of WAPM, vice president SAFOG, past president of so many societies, ISPAT, Foxy, ISAR, member FIGO Guideline Committee, Dean ICMU, Managing Director Global Rainbow Healthcare and Rainbow IVF Delhi, and has published innumerable papers, innumerable chapters, and so many books, editor of series of step-by-step books, chairman of Smriti, and has doing a lot of social work, and now actually sir is the president of Rotary Club Agra as well. So sir, I would like, thank you sir for encouraging us and joining us today, and please invite you to say a few words and share some wisdom about this topic as well. Sir, you have to unmute yourself.
Thank you very much, Foxy Perinatology Committee, Vaishali, Diksha, and Dr. Ragini for inviting me here. As probably I have to leave a little bit for a half an hour guest appearance somewhere, I'll come back here. So let me just share a couple of slides on which I feel everyone should know about RH. And if you don't mind this, so let's see what RH is. And so firstly, a lot of people ask me, does it have a genetic factor? And I'm sure Vandana would say, so it's not only RH or D antigen, it's D, C, small d, and small n, and the A and B. And it lies on the chromosome 1, the D, the RH antigen, so it's here. So that's the genetic aspect which we all should remember, and there are 3 of them. So sometimes these minor ones also can give a problem. And then of course everyone should be familiar with this RH negative mother antenatal algorithm. This I will WhatsApp to us, so all those who have attended can just go through how we should go about managing pregnancy with RH isoimmunization. And obviously the questions will come forward that if the mother is RH positive, ICT positive, what should we do? How much antidote should be given? 1 dose, 2 doses, post-delivery 1 dose, post-delivery 2 doses. Now it's 2 doses post-delivery also. So I'm sure those things we will discuss in the panel and come out with some great guidelines. Last webinar, Dr. Jaideep and Dr. Prashant in the INSWOG and ISPAC webinars discuss these doses, and we need to have, Vaishali, we need to have a TOG, Foxy guideline on exactly how RH, because everybody is managing it differently. So we need to have a uniform guideline as we have for perinatal screening and antenatal screening. So thank you once again, all the best for this panel. I will be in and out, I'll be listening to you, and where needed, I'm sure going to be answering questions.
Thank you so much, sir. And I know you love teaching, and you always make things so simple for us to understand and with crisp take-home messages. Thank you, sir. And we would love to have your inputs throughout the webinar as well.
Sure.
Now, I would like to invite Dr. Ragini Agarwal, ma'am. Ma'am is the current Vice President, North Zone of Foxy 2019-20. Ma'am is a fellow in clinical gynec endoscopy UK, has done a master's in cosmetic gynecology and laser. She's the head department of cosmetic gynecology, Pratiksha Hospital, Gurgaon, senior consultant of Advanced Clinic for Women's Health, Gurgaon, and a founder member of the Gurgaon Obs and Gynae Society, a founder president of the Haryana Association of Obstetrician and Gynecologists, President-elect of the Aesthetic and Regenerative Society India, President of the Indian Academy of Cosmetic Dermatology and Gynecology, and a founder-president of the Haryana Association of Gynec Endoscopy. Thank you so much, ma'am, for being a part of this webinar as a guest of honor. And I would invite you to say a few words.
Thank you, Diksha. And thank you, Vaishali, for inviting me for this very important topic. Although RS negative seems to be a very simple and very day-to-day thing, but still, as Sir has said, still people are managing it not according to the guidelines, what they think it is better. And management of RS negative is totally changed. Now we are managing people, those babies by the PSV of the baby. Still very few people are aware of this thing. Okay, now the management is changed, whether NTD should be given at 28 again to be repeated or not. So Vishali, it will be a wonderful thing if in your tenure you will come up with the guidelines for the RS negative and have a TOG, and having this idea of having this webinar series on this topic is very good. And not only, I'm really very excited to interact with the many societies, president and secretary, not standing between you and academics and the delegates. I thank you and wish you very, very best. Over to you. Vishali, unmute kar lo.
Thank you, Rakini ma'am. Thank you, Narendra sir. And like you have said, yes, it is a need to make some guidelines and release a uniform guideline about this very burning issue and burning topic. Thank you so much for the guideline and for your guidance, and hope you can continue to be with us during this entire scientific session. Stay with us, ma'am.
Thank you so much, ma'am. And now I would like to introduce and thank all my panelists who are here with us on this Sunday. And I'm sure would really help bring some clarity on this topic and would solve a lot of the queries which all our members might have on how to approach Rh negative pregnancies and how to use anti-D immunoglobulin and how to manage these pregnancies as well. So to begin with, I invite Dr. Vandana Chadda. Ma'am is a senior obstetrician and gynecologist. She's a fetal medicine specialist and has done her postdoc fellowship in maternal fetal medicine from Toronto. Her areas of interest include fetal imaging, fetal interventions, fetal therapy, multiple pregnancy, fetal genetics, and fetal autopsy. She's an MBBS multiple gold medalist, has won best papers in AUGD, NARCHI, and SFM. She's been awarded the IMA Distinguished Service Award, the IMA Young Achiever Award, the Chief Minister Award for Fetal Cardiology, the Delhi Medical Association Best Worker Award, and is very actively been organized in many academic activities with more than 20 index publications. On a personal note, I think Dr. Vandana is a great orator and would bring a lot of clarity on this subject and solve many of our queries about the fetal medicine aspect of this topic. Welcome, Dr. Vandana. Is ma'am here? Is ma'am offline? Okay, next I invite Professor Richa Singh. Richa Singh ma'am is a professor Obs and Gynae in SN Medical College, Agra. She's a past secretary of Agra Obs and Gynae Society, has been the organizing secretary of 4th midterm UPCOG Agra, and is a recipient of innumerable awards. Kamini Rao Yuva Oration at 53rd AICOG Guwahati, the Professor Usha Sharma Oration, Foxy Corion Award, Jagdishri Mishra Award, and the Karan Gupta Award for Best Poster and Jamna Prasad Award for Best Paper. Welcome, Richa ma'am. We are very glad that you could join us today. Richa ma'am, can you hear us?
Yeah. Yes, now.
Yeah. Ma'am, your volume is very low.
Volume is low.
Yeah. You're not very audible. Yeah. Next, I welcome Dr. Dipali. Dr. Dipali is Assistant Professor in Department of Obs and Gynae, All India Institute of Medical Sciences, New Delhi. She has 9 years of teaching experience. She's member of the AOGD Endoscopy Committee, Executive Committee member for the Network and Alliance for Non-Profitable Activities and Knowledge, and has several international and national publications in, as well as written chapters in various books. Welcome to the panel, Dr. Dipali. Is she here?
Dr. Diksha, you continue. Invite all of the panelists.
Yeah. Next, I welcome Dr. Poonam Agarwal. Welcome, ma'am. Ma'am is the Director of Home Hospital and Research Center, Firozabad. She is the President of Firozabad Obs and Gynae Society, member of IMA, FOXY, CELSA, IFUMB and IFS, Secretary Bharatiya Lok Kalyan Samiti, has a special interest in minimal invasive surgery and high-risk pregnancies. Ma'am has attended various conferences as faculty, and we are very happy that she can contribute her vast experience in treating high-risk pregnancies to this panel.
Thank you, Dr. Diksha. Hello to everyone. My hello to everyone, and thank you, Dr. Diksha, for giving me the opportunity.
Yeah, thank you, ma'am. Next, I welcome Dr. Vyanchana Pandey. Welcome, ma'am. Ma'am is a director, Janhit Hospital, Karchana, Prayagraj. She has an interest in high-risk pregnancy and obstetric emergencies and adolescent healthcare. She has been actually running a medical facility established in rural as well as suburban areas for the last 25 years. So, ma'am, I'm sure we would benefit with your years of knowledge and expertise in this area. Welcome to the panel, Dr. Priyanka. Priyanka is the Secretary of Meerut Obs and Gynae Society. She's done an MBBS from SMS Jaipur. She has been awarded the Savai Man Singh Gold Medal. She has a fellowship in lab gynae surgery. Her field of interest lies in minimal access gynae surgery, and she has more than 10 years of experience and numerous publications and presentations to her credit, including the CS Dawn Gold Medal, Krishan Mukherjee Gold Medal, and the Prabhu Dayal Baveja Memorial Prize. Welcome, Priyanka, to the panel.
Hello everyone. Hello Richa ji, hello Naren sir. I think the discussion would be a very enlightening and a fruitful one. Thank you.
So I invite Dr. Vishali to take over the proceeding and to start the discussion.
Thank you, Dr. Diksha, for this wonderful introduction of all our expert panelists. And like Narendra sir had just told us about Rh negative pregnancy in brief, in fact, he showed us the algorithm also. So today's panel discussion, what we aim to do is discuss more of clinical cases and give very clear-cut take-home messages to all the audience who have logged in with us today. So let's hope to have a very interactive session, and I request all the people who have logged in to send their questions so that we can answer them. As we know, Rh negative pregnancy, earlier we have a lot of fetuses used to be lost, babies used to be lost, but now with the advent of molecular science has advanced so much that today we can find out the fetal blood by cell-free fetal DNA, or with the advance in the ultrasound, with the MCN ASV ratio, we can identify which fetus is at high risk. And of course, with the advent of anti-D immunoglobulin, the entire scene has changed, and we are the loss of fetus due to RH anti-D, RH isoimmunization is less because of all these newer advances. But yet, still today, such cases do occur. So the aim of this scientific program is to give clear take-home messages on the correct use of anti-D immunoglobulin and in which scenarios. So starting with the first question, this is for Professor Richa Singh. Yes. So this is a clinical case scenario. I'm going to just explain to you and then we'll discuss about it. This is a Gravida 2 Paravan living 10 weeks pregnancy. Her blood group is BRH negative. And she has come to your OPD for routine antenatal registration. So how would be your clinical approach? Is the history significant? Would you like to ask for husband's blood group? Is it significant? What about her past obstetric history? Is that also important, and in which way? That is the first part of the question. And the second part of the question pertains to ICT. That when will you advise ICT to this patient and subsequent ICTs when they should be done? Yes, Professor Richa.
Yes, so since she has come, can you hear me?
Yeah.
Yes, please go ahead.
So she has come for the first time, and if she's giving history that she has a B negative blood group, that means she's aware of this fact. So she must be knowing whether her husband's blood group was tested in last pregnancy. So we can take the history of husband's blood group. If she doesn't remember, then we go in for doing the blood group of husband. And we can also take history if the child's blood group was done in the last pregnancy. Then a detailed history, obstetric history of last pregnancy, whether there was any history of suggestive of any complication like threatened abortion or manual removal of placenta or abruptio placenta, any such history in previous pregnancy which may have significance. Then whether anti-D was given, because whenever we ask them about anti-D, any patient, we give a suggestive history that in postnatal period any expensive injection was administered, then she remembers and gives the history also. And whether it was given in antenatal as well as postnatal period or a single shot was given. Then what was the baby's blood group and any complications which occurred in the baby in the postnatal period. Usually the first child doesn't suffer any complication, but there may be history of hyperbilirubinemia or phototherapy. Any such history should be recorded. Now coming, if the baby, she remembers a baby's blood group and that was negative, then it will suggest that the father is heterozygous if the father is positive. And if the father is negative, then there is no worry, but that rarely happens. Mostly the fathers are positive. Now comes the role of the genotype of the husband. So if the genotype is homozygous, the previous child was also positive, then we have to go for intensive care in this woman. If the father is heterozygous, then there may be a chance that the previous child was negative or this child is negative. So if the facilities are available and the patient is willing, then we can go for cell-free fetal DNA testing, where we can come to know of the fetal blood group. So in this pregnancy, we have taken the history, the past obstetric history, the past history of anti-D, the past history of any complications in the baby. And now coming to a conclusion that we are assuming that the father is positive and heterozygous positive. So in this case, now comes how will we proceed in this pregnancy. So at 10 weeks, the history should be whether she had any incidents, any episode of bleeding per vaginum or threatened abortion in this pregnancy. Then after that, any history of past blood transfusion or any trauma on any such history which may suggest feto-maternal hemorrhage. So that is as regards history. Now coming to the investigations, at her first antenatal visit, indirect Coombs test has to be done. And if indirect Coombs test is usually in the first trimester, we find it, we are assuming that it is negative. Then on this, if it is negative, then we can either repeat indirect Coombs test every 4 weeks, or we can repeat it at 28 weeks before giving anti-D. And if the indirect Coombs test is positive, then we have to go for the titer. And if the titer is below the critical level, which can vary from lab to lab, it can be 16, 32. So if it is below the critical level, then we will repeat indirect Coombs test every 4 weeks for follow-up. And if it comes in the above the critical level or at critical level, then every 2 weekly we have to go for titers. And when it shows a rising trend, then that should be alarming. And if it is the second trimester, then either Doppler or even amniocentesis is to be done to find out whether what is the level of
Richa, we'll come to amniocentesis and all that later on. So, thank you. You have very effectively covered the entire question about how the history is so relevant, husband's blood group, why it is relevant, and the past obstetric history, especially because if there is a history of a previous affected pregnancy, then in this subsequent pregnancy, the fetal affection can be at least 2 to 3 weeks earlier, at an earlier gestation age as compared to the previous pregnancy. And of course, regarding ICT also, you have covered that it needs to be done frequently. Every 4 to 6 weeks is what they say for primary gravida, and for a multi every 4 weekly till 24 weeks of pregnancy, and after that every 15 days. Now, you also spoke about the critical titer 1:32. It varies from center to center, but of course 1:32 ICT is a critical titer. A sudden increase in the ICT titer is again a critical indication. So now this coming to my second question. This is for Dr. Poonam Agarwal. Is she there? Yeah, yes, you are there. So now this patient is there. The ICT is positive. ICT positive does not necessarily mean that baby is affected. But then if the ICT, it has crossed the critical level, and if the agglutination is a lot, or the damage to the fetal erythrocytes is a lot, then this leads to the hemolytic diseases of the fetus and the newborn. So I would just like you to enumerate and tell us a little bit more about the hemolytic diseases of the fetus and the newborn. Unmute yourself.
When maternal antibodies cross the placenta and reaches the fetal blood cells, then these antibodies damage the fetal blood cells. And when fetal blood cells will get damaged, it will lead to the process all of this disease, erythroblastosis fetalis. It is the spectrum of disease. When it is in its minor form, it will cause congenital anemia. The fetus will get anemic, and we will diagnose it by we can diagnose it by color Dopplers, by middle cerebral artery PSV. Okay. Then if congenital anemia worsens, then first of all, this hemoglobin, when it will break down, it will lead to formation of serum bilirubin. But in the fetus, what happens? That all serum bilirubin will cross the placenta, will go to the mother, and the maternal liver will metabolize it, and in the fetus there will be no jaundice. But when this fetus will be born, then the jaundice will be there in first 24 hours and will cause icterus gravidarum. If this anemia worsens, and if more and more blood cells are getting damaged, then it will cause congenital heart failure in the fetus, and extramedullary erythropoiesis will start, and it will lead to hydrops fetalis, in which there will be ascites, there will be generalized edema. It will increase the chances of perinatal mortality and perinatal fetal death, because if hydrops is there, then it is very critical condition, and when hydrops delivers, and it usually dies, it may cause intrauterine death too. Therefore, this spectrum of disease has 3 forms: congenital anemia, icterus gravidarum, and hydrops fetalis. When in the neonatal affection, what occurs? That in neonates, there will be neonatal anemia, when we will diagnose it by cord blood examination. But if the anemia, this serum bilirubin rises, then it will cause jaundice, hemolytic jaundice of the newborn, and then it may worsen. It may, if it is levels are increased and the serum bilirubin crosses the level of 20, then it will cause the blood-brain barrier, and it may cause kernicterus, which is a serious condition. Therefore, in neonate, it can cause anemia, jaundice, kernicterus, the low body tone, lethargy, and all these things.
Yeah, that's absolutely right, Dr. Poonam, and that is the reason we do not want our fetus to suffer these hemolytic diseases. And not only that, it can affect the mother also. There could be preeclampsia, polyhydramnios, so all the complications related to the big baby like PPH, instrumental deliveries. And there's a very interesting syndrome called as maternal syndrome, in which there is urticaria, edema, and proteinuria. And this, when the pruritus, and that means there's an imminent fetal death. So coming to our next question, this is for Dr. Vandana Chadda. Yeah, Dr. Vandana.
Can you hear me?
Yeah, we can hear you. The question is, so we do not want this feto-maternal hemorrhage to occur. So which are these procedures which cause feto-maternal hemorrhage, and is there any way that we can reduce the feto-maternal bleed? Yes, Dr. Vandana.
Yeah. So as a fetal medicine specialist, we do a lot of procedures. Whenever we do an invasive procedure in a fetus, we always try to give anti-D. So starting from the first trimester, we have a procedure called chorionic villus sampling, which would require anti-D and multifetal reduction that we do in the early first trimester. After 16 weeks, if you're doing an amniocentesis, that requires anti-D, and laser ablation of cord or laser ablation of placental and anastomosis, and late second trimester fetal cord blood sampling, and so on. The thing here is that anything under the 12 weeks of gestation or around the late first trimester, the risk of causing a isoimmunization is very low because of the low fetal RBC volume. So I think in less than the 12 weeks, if you have done a procedure, even a 50 dose would be, a microgram dose would be adequate to cover the thing. But if you don't have that dose available in your city, you can use the 300. And anything less than 20 also, you don't really need to check the volume of the feto-maternal hemorrhage that the procedure has caused. You can simply give a 300 microgram if you're doing an amniocentesis, say between 15 and 20 weeks of gestation. That should suffice. So in late pregnancy, if you're doing something like an external cephalic version and you end up with doing more massive feto-maternal hemorrhage, then definitely I'd like to quantify the amount of feto-maternal hemorrhage that has happened by, say, a test called the Cleo-Betke test. And based on rough estimation that for every 30 ml, I would need 300 micrograms. So for 15 ml, I would need 300 microgram. I would like to titrate my dose of the anti-D with the amount of feto-maternal hemorrhage that has happened in a later pregnancy. And just a couple of quick comments. If we do see a critical titer in the pregnancy, say more than 1 in 32 for my center, I would probably not repeat the ICT. I would just straight on go to the MCA PSV monitoring. And then we do see in India, at least in Delhi, we do see a lot of anti-C along with the anti-D. So anti-D is the common one, but there's sometimes more hemolysis, which we see in combinations like C and D antibodies. And not here, but we've managed a few KEL antibodies also. So those are the other hemolytic diseases that we see commonly in the fetal and the neonatal, which are the rarer antigens. So it's RCOG guideline actually says that you should do a full minor antigen antibody workup, not just the anti-D when she comes for the first visit, also at the 28 weeks, not just the anti-D, but the other minor antigens also. So that would be a very important take-home message for the general obstetrician. Those services would be available with a blood bank in your city, if you can check with them.
Yeah, that's a very valid point you have made, that not only anti-D, you should look for C and null or KEL. All these are also very important.
KEL,
so, yeah. So Next question is for Dr. Deepali Garg, and I request all the panelists to please contribute and whatever your opinions about the ongoing discussion, please do.
Regarding the sensitizing event, as discussed in the last question, ma'am, I would just like to add that ectopic pregnancies, molar pregnancies, and even women who present very early on with abortions or for a therapeutic termination of pregnancies are the one where we really need to also be checking the RHG levels and making sure we are giving the anti-D immunoglobulin to prevent the isoimmunization.
That's a very valid point, Diksha. So let us take that in a case scenario questions, so it becomes more clear. This is a question for Dr. Deepali Garg. Question is, primary with 6 weeks pregnancy, she's B negative and she's had spontaneous abortion. So will you give her anti-D? Is there any need to give her anti-D, and why or why not?
Actually, according to all the guidelines, since it is logical, because before 38 days after conception, the antigen doesn't express over the fetus RBCs. So it is not logical to give, because chances of getting alloimmunized at this period of gestation is very less. Am I audible?
Yes, yes, please go on.
Okay. So since it has been proven that the antigen doesn't express before 38 days, so it is not, you may give or you may not give, but most of the guidelines, they suggest that there is no need to give anti-D.
What will you do? What would you prefer, Dr. Deepali?
I will not go for, if the patient is clear-cut, she is having 6 weeks period of gestation, the abortion is spontaneous and it is complete, and there is no history of any instrumentation. Because RCOG says,
your panel say, what do that?
We would like to check for the fetus in whether it was a missed, it was a blighted ovum, or did she have a fetus?
Spontaneous abortion. She's come to you. She has had a spontaneous
abortion. Can be both. It could be of a blighted ovum as well, or with a fetus with cardiac activity as well.
Does it? You think it is significant? That will. How will you decide depending on this?
Doesn't have any fetus. No question of having any RH antecedents over there. But if you have a fetus, then just to prevent any further delay, I would like to give a dose to her.
Okay, so Dr. Priyanka says she would like to give a dose. Anybody has all of the panelists, please do express your opinion, yes or no. Because we would like to give a clear-cut message.
Within 6 weeks, if no instrumentation, I don't think I like to give.
Okay, and anybody else? Dr. Poonam, Dr. Vanjana? Any opinion?
I think we don't have a very large case control study. We don't have a randomized trial yet published where I can...
No, in your practice, what will you do? The question is, what will you do?
In my practice, I used to give.
So we don't have a published trial.
Yeah, so listening to all our panelists, the overall opinion is this, that yes, you should give, though there are no, like Dr. Vandana said, there are no RCTs for it or against it right now, but the benefit is huge compared to, there are no associated adverse effects. So if you have a patient with 6 weeks pregnancy with a spontaneous abortion, the take-home message would be, give her the dose, give her the benefit of that anti-D immunoglobulin, prevent further isoimmunization or affection of further future pregnancies, and give the dose. That is the message here. And like Dr. Deepali mentioned, that after conception, within 38 days, the RBC spittle erythrocytes are formed. So yes, these doses may definitely benefit, may or may not benefit, but the advantage is much more than the disadvantage. So message here is, please do give. So second question is to Dr. Vanjana Pandey. The question here is for you. Gravida 2, para 1, living 1, 7 weeks of pregnancy, a ruptured ectopic. Surgical intervention has been done, a patient is stable. So what is the dose of anti-D that you would like to give?
It's a very relevant and practical point, ma'am. And in such cases, we actually go in for 50 micrograms of anti-D. And since we are going in for surgical intervention, in case we had treated it by medical management, in that case, we could have avoided the anti-D. But since surgical intervention has been done and it's ruptured ectopic, we definitely will give 50 micrograms of anti-D.
Right. Yes, anybody wants to add? Yeah, please
Yeah,
go.
even in medical management, I think it should be given.
Yes,
Based
absolutely.
on our discussion, yeah.
Yeah, it's
Yeah,
open for discussion. Please
It's
contribute.
a controversial point actually, like in medical abortion for ectopics as well. Again, have a look at the amount of beta HCG, the presence of the fetus, presence of cardiac activity in the ectopic. These are little bit of clues which can guide you through. But again, as Vandana ma'am has already said, we don't have large RCTs over it. Plus for ruptured ectopic, the amount of hemorrhage also matters a lot. We have seen ruptures with 3 liters of hemorrhage, and we have seen ruptures with just 50 ml, 100 ml in the pouch of Douglas. So it has to be a clinician.
Actually, the patient in this case is stable. So obviously the amount of hemorrhage which has occurred is not that much. So in that case, the amount of feto-maternal hemorrhage is acceptable, and we can go in
This is
for
an
50
interesting point. Are we worried about the maternal hemorrhage, or are we worried about the feto-maternal hemorrhage? Now, these are two different points, isn't it?
It's
so,
about the feto.
like Dr. Yeah, so it does not really matter. And like Dr. Vandana said, Vinjana said, sorry, that you have done surgical intervention. This patient, yes, does definitely require. And 50 micrograms, somehow it is not available in our country yet. So the minimum dose you should give here is 150 microgram of anti-D immunoglobulin, since 50 is not available. Professor Richa also spoke about medical MTP, and she says that yes, anti-D should be given to all medical MTP. I wholeheartedly agree with you, Professor Richa. Does anybody want to disagree to this, the panel? So the message here, which many gynecologists, obstetrician in the busy OPD, they may be giving MTP pills, prescription and all that. And at that point, they may miss giving this anti-D prophylaxis to that patient. So what we are here today doing is creating an awareness amongst our colleagues, amongst the obstetrician, that when you are advising a patient regarding medical MTP, please advise her there and then for the indicated patients for anti-D immunoglobulin. Usually, where is anti-D injection given? The site? It's a practical question.
Deltoid. On the deltoid.
Yes, it should be given at the deltoid, because if you give it the gluteus, then it gets the dose gets lost in the subcutaneous tissue. So ideally, you should give in the deltoid. So whether there is a vesicular mole or ruptured ectopic or incomplete abortion, please do give anti-D immunoglobulin. Now, this is another case. This is for Dr. Priyanka. Yes, Diksha, you want to add?
Yeah. To say any other, like when I was, yeah, can you hear me?
Yeah, we can hear you now.
So when I was reading about there, yeah. So also, has anyone observed any adverse effects with anti-D? Because actually, when I was brushing up, it's very clearly mentioned in many of the guidelines that it should be, we should also be having all the anaphylaxis medicines ready, because there are a few instances of anaphylaxis also been reported with anti-D. So regarding administration, I think we have to be also a little bit careful that, give it in a supervised way.
Yeah, it should be given in a hospital setting, obviously under supervision. So now coming to our next question, Dr. Priyanka Garg. Yeah, Dr. Priyanka, this question is for you. This is again a clinical case. Gravida 3, para 1, abortion 1, living 1, 18 weeks pregnancy, and she has come with incomplete abortion. And post procedure, will you give her anti-D immunoglobulin, and how much? How much would be the dose?
Actually, she's a gravida 3, para 1, abortion 1. and she is now 18 weeks of pregnancy. So I probably believe that her indirect Coombs test must have been done by now, because for multigravidas, that is gravida 3, we start doing ICTs by 12 weeks of pregnancy and get it down repeated every month. So my decision would also depend upon the ICT report, and if I take it as negative, she was ICT negative and now she's aborting at 18 weeks of gestation, I would like to give her a full dose, that is 300 microgram of anti-D immunoglobulin after my evacuation procedure.
Yeah, anybody wants to differ? I think the panel agrees. So for 18 weeks of pregnancy, the coverage is 300 microgram is the dose. So up till 12 weeks, till first trimester, 150 microgram. After 12 weeks, then the dose increases to 300 microgram. There's another interesting case. Suppose there's a patient 16 weeks pregnancy with recurrent episodes of bleeding. So what will be the dose of anti-D? Anybody from the panel can answer.
Yeah, if we give an anti-D of 300 micrograms and then we repeat the ICT, if she's having recurrent episodes, we repeat the ICT. If the level of immunoglobulin in the mother is sufficient, then ICT will come as positive in 1:4 titer. And if the ICT becomes negative, means those immunoglobulins level has gone down. And usually at 3 to 4 weeks, this will occur. And then if she's having hemorrhage, we have to repeat the dose of anti-D again.
Right. So message here is like Professor Richa said, that if there's recurrent bleeding, yes, you can repeat the dose of anti-D.
And this is a very tricky situation in cases of placenta previa. We have many patients who keep on bleeding and bleeding. So the Klehr-Betke count, the test, it works a lot in all these things, because you have to estimate the amount of feto-maternal hemorrhage as well, and not just keep on giving repeated doses again and again. Dr. Vanna, ma'am, can you please enlighten us something else?
We'll come to that, Doctor. We will come to that eventually. Let us complete one topic. All right. But that's a very valid point that you have raised. So we are still on anti-D immunoglobulin and we are just discussing all the different case scenarios. So another case scenario, this for Dr. Poonam, this is for you. Can you just enlighten us about the routine antenatal dose of anti-D immunoglobulin? And there is single dose and then the double dose. So what do you recommend, and can you just guide us about that?
Actually, routinely, we have to see the what is ideal. It is 2 dose, because by 2 dose there will be high level of titers at the time of delivery, which will cover up the feto-maternal hemorrhage, but compliance is less in 2 dose regime. Therefore, single dose regime at 28 weeks is recommended. Practically, we are using single dose antenatal anti-D injection at 28 weeks of pregnancy. But ideally, if we see, then the double dose has much advantage as compared to single dose. Then double dose, if we are using, then we can use it at 28 weeks, and then we will repeat the dose at 34 weeks.
Right. Anybody wants
because
to...
we see that at 28 weeks, when we give the anti-D injection, the antibodies which are formed, their level starts declining. And at term, sometimes it declines to low levels and it cannot cover the feto-maternal hemorrhage. Then that's why 2 dose is better as compared to single dose.
So there has been different thoughts, like Dr. Poonam said 2 doses can be given. The risk here is, if you have given the first dose, both are one big dose divided into 2, both are smaller doses. If you have given the first dose and the patient misses the second dose, then that advantage is lost. So if you feel the patient is not compliant, then it's okay, just give the routine anti-D prophylaxis at 28 weeks of pregnancy. What is important to know, that before you give anti-D prophylaxis at 28 weeks of pregnancy, please do an ICT. Important to do ICT, and only if the ICT is negative, then only giving this full dose of 300 microgram at 28 weeks of pregnancy. So next question is for Dr. Deepali Garg. This question is regarding post-delivery immunoglobulin. How much is the dose and how will you give?
Post-delivery, the standard dose is 300 micrograms single dose within 72 hours of delivery, or as soon as possible, but within 72 hours. But if someone misses that 72 hours, it can be given up to 10 days. It has some partial benefit, and it has been seen that it has even some effect till 28 days after delivery. But we have to give in the non-sensitized RH negative women as soon as possible after confirming the blood group status of the baby. If it is RH positive, then we have to give the dose 300. That is standard, but in RCOG they recommend the 100 microgram dose. And they also recommend that we have to do the estimation of the feto-maternal hemorrhage, and accordingly we have to cover up that feto-maternal hemorrhage with additional doses. We have to calculate the dose and we have to give additional doses later on, because in 50% of the cases there are no significant incidences during delivery, which can prove you that there are high chances of getting high chances of more feto-maternal hemorrhages. So ideal is that we should calculate the dose and give the dose.
So here, Dr. Dipali, we are talking about routine post-delivery prophylaxis and anti-immunoglobulin. So like you said, 300 micrograms should be given, and as early as possible and up to 28 days. Even if you give, suppose patient has not gone and come back for follow-up visit, and yet patient has not taken anti-D, then you should give it. It works till up to 28 days post-delivery. And another important message here is, before you give this anti-D dose, you should look for baby's blood group, and also you should do DCT. DCT and baby's blood group are two investigations that are needed before you give this dose. So we have been talking about feto-maternal hemorrhage and Clauber-Bettke test and so many things. So this next question is regarding this. This for Professor Richa Singh. And the question is, this is a patient, gravida 2, para 1, living 1, 34 weeks of pregnancy. Blood pressure is 160 by 100. And she has undergone diagnosis as abruptio. She has undergone emergency LACS. Half liter of retroplacental clot has been removed. That indicates that there has been a huge feto-maternal hemorrhage. So how will we manage? What are the tests done to assess feto-maternal hemorrhage? When I say how do we manage, we do not talk about the obstetric part of the management of such a patient, probably in shock or all that. We are talking related to the RH negative part of the management.
Yeah, as we can see in this case, the amount of feto-maternal hemorrhage suggestive is more than normal. Whenever any episode like abruptio or MRP has occurred, these are the cases where estimation of feto-maternal hemorrhage becomes especially important to calculate the dose of anti-D which is to be given in the postnatal period. So in this Clauber-Bettke test is done for the estimation of feto-maternal hemorrhage, and this is a quantitative test. So what is suggested is that before this Clauber-Bettke test, we go for a Rosette test. The Rosette is a qualitative test. So in the Rosette test, we see the number of clumps which form, because the fetal RBC form a flower-like rosette, and then these clumps are seen under the low power microscopy. If under 9 low power microscopy we are seeing less than 3 clumps, it usually means that the feto-maternal hemorrhage is less than 15 ml of fetal RBC or 30 ml of fetal blood, and a quantitative estimation is not required. A single dose of anti-D of 300 microgram will do. Now, if the Rosette test gives a positive test, that is, we find 3 or more clumps or such rosettes under 9 low power field, then we have to go for a quantitative estimation by Clauber-Bettke test, which is more specific. In this test, the principle is that the fetal RBC have fetal hemoglobin, which is more resistant to acid elution than the adult hemoglobin, which is present in the maternal RBCs. So in the maternal blood, we do acid elution, where the adult hemoglobin will be washed off from the maternal RBC and the fetal cells will retain their hemoglobin. Now they are stained, and then we examine how many these pinkish red cells will appear, which show fetal RBCs, and the maternal RBC will appear as ghost cells. Now the percentage of fetal cells is to be calculated. So the 2000 cells are counted, and the percentage of fetal cell, that is number of fetal cells over the total RBC counted into 100, that is percentage of fetal cells, is calculated. And when we multiply this percentage of fetal cells into 1.7, we will get the number of vials of 300 microgram of anti-D which is to be given. This is a simpler formula where we are multiplying it with 1.7. Otherwise, a detailed formula is where the percentage of fetal cells, you divide them by 50 and then multiply it by 30. But easier is that you multiply the percentage of fetal cells with 1.7. If you get your answer in a decimal, as we do, it is 0.5 or more, rounded up to a whole number and increase the number of vial. If it is less than 0.5, then you drop it. So depending on it, we will get the number of vials which are to be given. And if the number of vials are more than 5, the maximum intramuscular dose of anti-D which can be given is the 5 vials, that is 1500 microgram in 24 hours. This we have to remember when we are giving in cases of large fetal-maternal hemorrhage.
Yeah, absolutely right. It's a very simplified way you have explained the entire thing. And like you said, in suspected cases where there is large bleed, please do give the extra anti-D dose that is required. And dose as high as 1500 is the international unit is a very good message given here. And when you give a large dose like this, you can give it through IV. The IM preparations are different, IV preparations are different. Suppose you do not have any kind of test, your lab is not doing the Clever-Betke, which actually it's an acid elution test. It's very basic test, and most of the labs do it. I agree, flow cytometry and immunoassay, a lot of labs may not do. But in case your lab is not doing, and you suspect that there is more fetal-maternal hemorrhage, so give extra dose, give that patient benefit of an extra dose, but do not give a lesser dose, always better to give a higher dose. Is that right? Does the panel agree to this?
Yes, 1 vial is extra given. All over the dose which is calculated, we add 1 vial extra, 300 microgram extra over that. And IV we can give 2 ampules IV 8 hourly.
Absolutely. So message here is don't undertreat. It's okay if you overtreat, but give the benefit to this patient of yours. So coming to the next question, this is for Dr. Vandana Chadda. Madam is fetal medicine expert. So let us take the benefit of her expertise, and this is specially directed towards you.
Hello? Can you hear me?
Can you hear me, Dr. Vandana? Can you hear the question? Is Dr. Vandana with us? Yeah, can you hear me, Dr. Vandana?
I can hear you, but now I can hear you. Yeah.
Yeah. So the question is for you specially. I'm going to ask you the question now. This is a patient, Gravida 3, Para1, abortion 1, living 1, 20 weeks of pregnancy with an ICT titer of 1:32. So what we want to discuss with you is management of ISO-immunized pregnancy. For this patient, what is the role of USG, imaging, Doppler, MCA, PSV? You know, if the titer if the value is more than 1.5 mom, what does it signify? So what is the fetal surveillance in such patients which are already ISO-immunized? Please go ahead.
Okay, so everybody can hear me? There's some streaming. Yeah. Okay, so if once I get a critical titer in my patient, then I quickly move on to what we call as the measurement or the surveillance of the middle cerebral artery using a graph by a very elegant study by Mary et al. And that graph plots the middle cerebral artery across the gestational age. And there is a median value and a 1.5 multiple of median value plotted on the graph. So The MCA is a artery in the baby's brain. It's the middle cerebral artery. It requires a little bit of technical expertise to take. Ideally, the baby should not be moving much, and there should be a good angle correction with as much zero angle as you can when you take the vessel. But otherwise, it's simple to do. And I would say if I have a critical titer, I would start every 2 weeks, and whatever my assessment of the situation, I might go to weekly or even bi-weekly MCA monitoring for my fetus. Once my MCA titers show that they are approaching 1.5 MOMs, that's my cue that I may be hitting a red flag. Clinically, I also, because the MCA is very highly sensitive and we usually would not miss a case, the sensitivity of MCA would be 100%. So in the good old days, we would do amniocentesis, look at delta OD 450 by Lilly's curve and all. I don't think I have done that in the last maybe 20 years. And it was in the late 1998 or something that I did after that, I think we have switched to MCA monitoring after 2000. And looking at the liver, the spleen and other parameters like a cardiac overload, placental thickening, these are also our clinical cues. Reason being that nowadays we see a lot of women have gestational diabetes. So you may hit a false positive occasionally when you're monitoring your MCAs. The MCA may be high because of certain other reasons why the fetus is overloaded, and you have to have a clinical feel of other things going on in the pregnancy so that you don't do unnecessary fetal invasive tests. So once I'm confident that the fetus is getting into a hemolysis, the multiple of median has risen above 1.5, we do arrange for a fetal cord blood sampling. Usually in the same setting, I would also arrange for a fetal blood bag because I don't want to puncture twice. And we give O negative blood, which is gamma radiated. We calculate our doses based on the fetal hemoglobin. We aim that we raise the hematocrit to 30, above 30 or so whenever we, and if our fetus is hydropic, then we don't raise it so much. We do a more sort of restrained transfusion for hydropic fetuses. So this is how we would manage, and we might need a retransfusion based on middle cerebral artery and other clinical parameters, and we monitor the fetus accordingly. So for a general obstetrician, once you have ICT positive, you have to do your MCA surveillance very well, because that's the biggest weapon that we have in our armamentarium to manage these fetuses and to decide on invasive transfusions.
So the message here is very clear for all the obstetrician that if you have such a patient who's already has to immunize, then you need
high sensitivity.
Expertise of a fetal medicine, and this is a teamwork. It's a multidisciplinary approach, and you do need a fetal medicine expert at this point of time. Basically, the principle behind this is fetal anemia causes high velocity, low viscosity, and then the subsequent Doppler changes. So please do not hesitate to involve a fetal medicine at this point, because Doppler studies, MCA PSV is the mainstay of the fetal surveillance, and this is what is going to lead us to a diagnosis and the decision that when intrauterine transfusion has to be done. So Dr. Vandana, coming back to you, we would like you to explain to us briefly the procedure. You're a fetal medicine expert, and you're well known in this field. So intrauterine transfusion, if you can explain to us briefly the procedure.
So I just mentioned it also. Once we have decided that our fetus is anemic and we need to do transfusion, it's an outpatient procedure. It doesn't require much, but ideally, if you're doing in a fetus which is viable, more than 28 weeks, you should have a OT setup also in the same unit where you are doing it, so that in case there is an emergency, you can still perform a cesarean to salvage the fetus. There is a small risk of IUD etc. in the procedure, so that should always be a backup. The fetus should be steroid covered again if you're doing it above 28 weeks. Now we can start doing the procedure as early as 20 weeks also. And it's a little bit difficult to do before 18 weeks or 16 weeks, but after 18 to 20 weeks, mostly it's easy to do a fetal transfusion. The site is usually the site we choose in the fetus depends on the position of the fetus. So I personally prefer the intrahepatic umbilical vein as my site for doing the transfusion. But if it's difficult to access, then you may choose to do in the cord blood. The cord site, which is the site where the cord is inserting into the placenta anteriorly, or where it is inserting into the placenta posteriorly, if it's easily available. If it's a very small fetus, or if for technical reasons you can't approach anything, even an intraperitoneal transfusion helps sometimes. So these are the way we choose our site. Again, we don't really anesthetize the mother. Other than local anesthesia, at least I don't use any other sedation. Sometimes if the mother is very difficult to manage, then you may sedate her a bit. And the fetus, if I'm using, if the fetus is very lethargic and the hemoglobin is less than 6, usually I don't need to sedate the fetus. Otherwise, we do give it some sort of a muscle relaxant to the fetus as well. So the type of blood that we use is always O negative blood. I always use a blood bank which checks the antibodies thoroughly, and which also gamma radiates the blood, because the fetus, the immune status of the fetus is such that we want to use gamma radiated O negative blood for our fetus. We use a 22 gauge needle. After local anesthesia, we choose our site, and once the needle is in, we just transfuse our O negative blood very slowly, about 1 ml per minute. We choose the amount of blood that we are transfusing based on the pre-transfusion hemoglobin of the fetus, as well as the hematocrit of our blood bag. So there's a set formula or general rule of thumb that we try to raise it about 4 times in one sitting. So roughly that would be my, or not ever exceed more than 15 to 20% of overall blood volume of the fetus. So clinically, we use a different parameters to decide on the amount of transfusion. We do a pre-transfusion hemoglobin, and we also do a post-transfusion hemoglobin of the fetus before we start, to document what was the hemoglobin before and after. Usually I would not transfuse if the hemoglobin is less than, say, 11 grams, more than 11 grams, but that rarely happens. If clinically you've judged well, mostly it's less than 10 grams when you start the procedure.
Right. Thank you, Dr. Vandana. You explained very simply, means you made the procedure very simplified, but I'm sure there's a lot of skill involved here, and that is the reason we need to involve a fetal medicine expert who, at this point of time, because if you do an intrauterine transfusion when indicated, these babies can be salvaged. Is that right, Dr.?
Yeah, it's also like the different clinical scenarios we face. So let me, for example, recently we managed a pregnancy which was gestational diabetes, and she was uncontrolled. MCA PSVs were always above the 1.5 MOM, but clinically I could not see the liver, spleen, and the baby looked very active and moving a lot. So I was more confident that the high velocity of the MCA we were getting were not really RH hemolysis, but was related to bad diabetes control and an overloaded a fetus with high blood volume. So you have to have a clinical sense also of other parameters that you are looking at in terms of the clinical situations that you have. And one take-home message, definitely, that if you are suspecting it, always overdo, never underdo your this thing. So an IVF pregnancy we manage where it's a donor and we don't know the status of the fetus or the status of the donor. We would always like to give the anti-D, not decide that we will not give it if you are suspicious of some unsolved data is there.
Yeah, with increasing ART pregnancies, there was in the last webinar one joke also about it, like how father's genotype or father's blood group is no longer important in today's scenario. But like you said, yeah, with ART pregnancies, you should give the benefit and give the anti-D immunoglobulin when required. So coming to Dr. Vanjana Pandey, this is for you. The question is, while delivering an ICU-immunized patient, would you like to take some precautions? What precautions?
Because basically we want to prevent feto-maternal hemorrhage and exchange, and therefore early clamping of the cord is very necessary in such cases. And besides, we should keep the cord lengthy, because in case in future we require exchange transfusion. So at the first stage, we must keep the cord lengthy. And also immediately we must go in for the blood sampling of the cord for blood group, for serum bilirubin. And so assessment has to be taken whether the baby's, what is the blood group of the patient, of the baby. And besides giving of methogen, nowadays we are not giving that, but we must not give it on the anterior shoulder if at all it is required. It is only after the delivery of the placenta. So these are the steps we must take into account. But
one more thing, don't do a manual removal, wait for a spontaneous separation.
Spontaneous expulsion of the placenta.
So I think you have covered most of the points. When an immunized, already ISO-immunized patient comes to you, you need to take a decision whether there is a severe affection, severely affected, whether she needs an intrauterine transfusion, or you should deliver her immediately, or whether she the ISO-immunization is mild and you can hold on, with surveillance and pull on till 34 weeks. That decision making at this point is important. And when you are delivering, you have covered most of the points. Now, there's a little controversy about early cord clamping, delayed cord clamping. All these years, we have been told that yes, in RH isomimized pregnancy, RH negative pregnancy, you should clamp the cord as early as possible. But now, new
actually, yes, ma'am.
Published.
The back pressure causes the back pressure. It causes the increase in the pressure of the blood flow.
Dr. Prinjana, you're not very audible. The point I was making here is now newer studies have been published by the Pediatric Neonatal International Journal 2016, which says that there is no role of delayed cord clamping in RH negative mothers who are delivering. There is no added benefit. So it's a slightly a change of opinion. Of course, more RCTs are awaited and more evidence is awaited. But
earlier why we were thinking is because of the risk of increase of antibodies which are traversing to the fetus. But in cases when ICT has been negative, there is no role of early cord clamping, because they say the extra amount of blood would be helpful to the fetus in combating anemia. So yeah,
there's a lot of benefit for delayed cord clamping. It improves, like you said, Dr. Priyanka, improve the hemoglobin of the baby and gives a lot of benefits. So today the guideline has changed from immediate early cord clamping to yes, you can wait for the cord clamping, but the important point is to keep the cord length long in case the baby needs an exchange transfusion or some kind of intervention. So coming to the last question, this is for Dr. Priyanka Garg. Role of exchange transfusion in a severely affected newborn. Can you just tell us briefly?
See, now the pendulum is switching over. We know that the major cause of affection of the baby is anemia and jaundice. So for fetal medicine experts, they have switched over to intrauterine transfusions. But for generalized centers like us, what we do is we do MCA PSVs. We keep on monitoring the babies, and once we suspect affection of the baby, we give a steroid cover and then deliver the babies at around 34 weeks of gestation. Then when we hand over the baby to the neonatologist, there comes a role of exchange transfusion in all these babies, and the indications are increasing jaundice, or a bilirubin level more than 20 mg% in the baby, or a hematocrit less than 11 g%. Again, the principles of exchange transfusion are similar to as intrauterine transfusions. We use O negative, gamma irradiated blood, and as Dr. Manna has elaborated, we'd like to check the blood for CDEK antigens as well. And then we exchange we do exchange transfusions. That is around 15 ml of blood is transfused, and similar amount of blood is taken out so that overloading of the fetus does not take place.
Yeah, very right, Dr. Priyanka. And then again, post-transfusion care is very important. These babies need follow-up for a long time. Almost 8 to 12 weeks follow-up is required. Post-transfusion phototherapy and follow-up. So basically like I said, it's a teamwork. You need the best of fetal medicine expert. You need the best of NICU especially when you know that this patient is iso-immunized already, then the NICU backup is so very important. One more point Dr. Vandana had made about intrauterine transfusion. So is it true, Dr. Vandana, that even for hydrops, if the fetus is already in hydrops and you do an effective IUT, there's a survival rate of as high as 80 to 90%?
Yeah, maybe 70-80% definitely. Another point I like to make is that we don't really do transfusions after 34, 30. I'm definitely not after 35. Right. So even I would like to deliver if a baby is above 34 rather than do intrauterine transfusion. I would like to do delivery and exchange. And yes, I have seen a fetus where we have transfused 5 times, where there was good exchange transfusion, sent home, and then came back with hemoglobin of 2 gram because no follow-up was done. This baby came back with 2-3 gram at 6 weeks or after birth. So very important, you tell the parent that everything is not over. Sometimes they will have hemolysis, antibodies do persist, and an exchange may be needed even at an interval. So much hard work can get wasted. So that message has to go across from the obstetrician also for these parents.
So we have a lot of questions here, and we have a lot of audience who are logged in and are watching us. So we have here an expert team of panelists, and I would like each of you to answer this question. In fact, I had a very interesting discussion yesterday with Dr. Manjula Appadur. She works with my very good friend Dr. Charmila, and her question yesterday, she had called me. She said that patient was given anti-D 300 microgram in the morning, and she came in the evening and she delivered in the evening. So what to do? Will you repeat the dose, not repeat the dose? Any of you can answer.
So, no need.
No need to. In fact, if you have delivered within 3 weeks of anti-D, you will not repeat the dose. So that should be covered. So if somebody has preterm labor at say 31 weeks and already you've given at 28 weeks, or for some hemorrhage you gave at 35 weeks and she delivers at 37, then you don't need to.
There is no need to repeat the dose. That's correct. There's another question. On what day of medical MTP should anti-D be given? This is by Dr. Neeti Sinha.
When we give misoprostol, it is given concurrently with the dose of misoprostol, because that will cause a lot of uterine contractions, and that is the time when you expect fetal-maternal hemorrhage to take place.
So, like you rightly said, Dr. Priyanka, it has to be given immediately. As soon as you give the tablets, it has to be given. So, one more question to the panelists, which I like to ask is, there's a full-term pregnancy and patient has come with a report of intrauterine fetal death. So, when will you give anti-D to this patient?
Immediately. After diagnosis.
Immediately or post-delivery, or?
We need to check the blood group of the fetus also, the IUFD, the blood
intrauterine fetal death. That is a clutch question.
We are really
the IUFD, you cannot
giving. Yeah.
This is treated as potentially sensitizing event. Yes. You have to take it as that event also, and you have to give the dose as soon as you diagnose the IUD.
As soon as IUD is diagnosed, you give it.
The husband's blood group is to be checked. If it is negative,
all prerequisites stay. Of course, all these prerequisites are there. So it has not. You do not wait for patient to deliver. You give it as soon as it is diagnosed. Then there is one more question from Dr. Sudha Bansal. She is a Gravida 2 patient, RH positive baby delivered in the earlier pregnancy. Now she is 12 weeks pregnant with bleeding, threatened abortion. So will you give anti-D and how much?
300 microgram.
150 at 12 weeks.
All right. So most of the questions that have come are what we have already discussed. There's one more question from Dr. Sonia Agarwal. Patient primary gravida IUD at 34 weeks of pregnancy, RH negative of course. And she has already taken anti-D at 28 weeks of pregnancy. So should we be giving her anti-D again?
Yes. Yes. Yes, we will be giving anti-D.
More than 3 weeks, you need to give. That's right. So I think we have covered most of the questions which have said, most of the questions are a repeat of what we have discussed. So I would like each of the panelists to give one take-home message for the benefit of our audience. Yes,
Yes, I will say that at first visit we should check the ICT, and if ICT is positive, we should follow up like this, and if ICT is negative, we should counsel the patient that at 28 weeks again ICT will be done and antenatal anti-D injection will be given.
I would like to say that we are doing a routine follow-up in all the RH negative pregnancies, but the cases which we are missing are those of first trimester early abortions, ectopics, medical abortion. These are the cases where generally obstetricians are missing giving anti-D. So that should, after this panel, all those who have participated should take care in such patients, always get their blood group done and take proper prevention for prevention of aluminization.
absolutely. Anybody wants to add?
Just an extra dose of anti-D is enough, and we must take care of that an extra dose should be given if required. And we must not withhold the injection just because of its cost or just because the benefits are much more.
The scenario is also not very gloomy when it is a fetal hydrops, as we have discussed. We are managing cases with fetal experts like Dr. Vandana Chadda. We are close to Delhi. We have that benefit. And we have 2 to 3 hydrops delivering normal babies. This is a truth nowadays. Plus, claim or bed K count is one thing which I would like people to learn to do, because this is such a simple test. Keep on hammering your pathologist. I too started it doing. My pathologist said, I will not do this. I said, no, you do it for me. I'll see it under the microscope. And then start giving extra doses of anti-D. This will take us a long way in managing Rh negative pregnancies. Thank you.
I think wonderful messages all our panelists have given, and I hope people who have logged in to listen to us have benefited. Each and every baby is salvageable. Even the hydrops baby is salvageable. We have the best of fetal medicine experts, best of NICUs, and do not hesitate to give anti-D immunoglobulin. Give an extra dose wherever indicated, but please do give. And yes, the abortion, medical abortion, spontaneous abortion, do give a cover of anti-D and help these mothers. So with this, I would like to thank all the expert panelists, and each one of you have been wonderful and given such wonderful message to everyone. Perinatology Committee Foxy is indeed very grateful to all of you. And thank you, Diksha, for organizing all this. Thank you to Dr. Narendra sir and Ragini ma'am for being here with us. Thank you, Science Integra TOG team, Bharat Serum. And thank you all of you. And most especially thanks to all the audience who are with us today. I hand over to Diksha for further.
Thank you, ma'am. I would also really like to thank everyone who logged in, and I hoped it was really interesting for you as well. And a big thank you to Vaishali ma'am for giving me this opportunity. For Foxy team of 2020, Dr. Alpesh Gandhi sir, Dr. Archana Base, Dr. Jaideep Tang sir, our guest of honors, Dr. Narendra sir and Dr. Ragini ma'am for guiding us, and all our panelists for being just so great, for solving so many of our queries, for giving crisp take-home messages, and to our academic support from Science Integra, TOG and Bharat Serum. In the end, I would be really remiss if I didn't thank all the societies who really supported us in this academic endeavor. So thank you to the President and Secretaries, Dr. Anupam Gupta sir, Dr. Shikha Singh ma'am, President of Alibad Society, Dr. Abhilasha Chaturvedi ma'am, Secretary, Dr. Meera Laktakia ma'am, Merit Society, Dr. Kirti Dubey ma'am, Dr. Priyanka, Dr. Renu Agarwal and Dr. Rashmi from Mathura Society, and Dr. Poonam ma'am and Prerna Jain from Firozabad. So thank you everyone, and hope to bring another webinar to North Zone really soon. Thank you, ma'am.
Bye, everyone. Thank you.
Bye.
Thank you.
Thank you.
Thank you to you also for giving us the opportunity.
Thank you.
Wonderful to meet you all here like this.
Thank you.